Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for June 18th, 2025. Thank you for joining us today, and thank you to the current Osteoarthritis Action Alliance sponsors who help support our work, which includes the monthly Lunch and Learn series. Now it is my pleasure to introduce today's speaker, John A. Batsis. Dr. Batsis is an associate professor of geriatric medicine and nutrition at the University of North Carolina at Chapel Hill. He is a geriatrician and clinician-researcher, board certified in internal medicine, geriatrics, and obesity medicine. Dr. Batsis provides care to older adults with obesity, multimorbidity, and frailty in both outpatient and nursing home settings. His research focuses on the interplay between fat and muscle in aging, conducting clinical trials aimed at improving physical function during weight loss, often using technology to enhance health promotion. He is also engaged in advancing methods to better understand the heterogeneity of aging. Dr. Batsis is funded by the National Institutes of Health and has published over 215 papers. He currently serves as chair of the Obesity Society's Clinical Research Section, co-chair of the Obesity Section of the Gerontological Society of America, and is an active member of international consortiums, including the Global Leadership Initiative for Sarcopenia and the Sarcopenic Obesity Global Leadership Initiative. He is also a member of the Osteoarthritis Action Alliance's Weight Management Task Group. The title of today's presentation is Beyond Weight Loss, Personalizing Incretin Therapies for Older Adults. Welcome, Dr. Batsis.
Thanks, Katie. And thank you to our sponsors here on the slide. So I'll just dive in here with a schematic first. Let me just make sure. There you go. Whoop. So one of the things I wanted to kind of just start the presentation with is talk about what happens with aging and what happens to body composition with aging. And as Katie shared, my interest is in the interplay between fat and muscle. So we know that individuals, as they age through the life course, gain fat, and really the peak fat mass gain occurs around this seventh to eighth decade of life. So one's peak amount of adiposity is really in the seventh to eighth decade of life. But what's really important as well is that there's a natural tendency for loss of muscle mass and loss of muscle strength with aging. And this is a term called sarcopenia. And this has been many definitions, but the latest definition is that of loss of muscle mass and muscle strength. And muscle mass and muscle strength actually peak in the third to fourth decade of life. And then I always like to share that it's all downhill from there. And what happens is that as one gains fat and one loses muscle mass and muscle strength, this crosstalk leads to insulin resistant, reduction in energy expenditure, and then with aging, this leads to reduction in protein synthesis and enhanced protein degradation, all which leads to a significant amount of metabolic dysfunction, which affects one's biology and ends up actually leading to a vicious cycle of ectopic fat deposition. And this is really important. Why? Because I always say a picture is 1,000 words, but you can see this as a cross-sectional image of an MRI, quadricep MRI. And the image on the left, it demonstrates significant hyperintensity. See the white that is within the quadricep muscle, that's all fat. And in contrast, you can see the MRI on the right, the image on the right, where there still is a little bit of a hyperintense signal, but much less so. This is really important because this fatty infiltration of the muscle is what's thought to lead to this phenomenon termed sarcopenic obesity. And sarcopenic obesity, it really is the synergistic challenge. It's a syndrome where you have increased risk of functional decline, falls, mortality, reduced quality of life, and most recently, we actually demonstrated an increased risk of cognitive impairment. So having obesity, diagnosis of obesity, and then having sarcopenia on top of it, the synergy is actually worse than either of the diseases or syndromes alone. So promised I was going to talk about the incretin therapies, and the two that I want to focus on today are semaglutide, GLP-1 receptor agonist, and tirzepatide, a GLP-1 GIP based agonist. And these are two of the formative studies that came out, and I'm sharing this not because they're older adults, because you can see the mean age in these cohorts is in the mid to late 40s. But what occurs in both semaglutide on the left and tirzepatide on the right, when compared to control group, the control group is the gray line. Semaglutide actually leads to profound weight loss. In this randomized controlled trial, uh, participants on semaglutide lost about 16% of their weight. However, when you stop these medications, there is a natural propensity for weight gain. So this is important to know because there's a high discontinuation rate, and I'll show some data on that. What we also know with tirzepatide is that there's a dose dependent effect on weight loss. And the figure on the right demonstrates 5, 10, 15 milligrams of tirzepatide respectively. And you can see there's a 15, 19.5, and 20.9% weight loss compared to, in those cohort, in those groups. So these medications are extremely effective and efficacious. Now, how about older adults? This is a post hoc analysis of all the SUSTAIN trials, which looked at semaglutide and a variety of different other agents, placebo, sitagliptin, exenatide, glargine, and insulin here. The take home for this from this study is that older adults respond similarly to weight loss and to changes in diabetes indices, specifically hemoglobin A1C. So that's really important to know that and the results are the same in older adults. And I'm using 65 and up as the cut point for an older adult. Now, are there trials in older adults? That's the $1 million question. And really, there's a paucity of trials conducted in older adults with obesity. This is one of the ones that a very well designed trial of semaglutide in individuals with heart failure with preserved ejection fraction. I share this because the mean age of this cohort was 69. Now, so there were individuals who were not older adults or designated as older adult, but for all intents and purposes, this is one that is really most approximates that of an older adult population. This 52-week trial actually demonstrated similar reductions in weight, but the changes in weight were much less than those in the formative trials that I showed you on the previous slide. What I want to bring to your attention here are a couple of really patient-reported outcome measures that are really critically important for older adults. One, physical performance, and they looked at the 6-minute walk test. Now, 6-minute walk is a marker for subaerobic submaximal aerobic capacity. It was statistically significant at 14.3 meters. Now, what is important to highlight is that you look at what minimally clinically important differences are. And depending on the cohort and the population you use, that's probably stretching as to whether or not this is clinically significant. And if so, it's really on the lower end. That said, they looked at the Kansas City Cardiomyopathy questionnaire, which is a marker of quality of life. The minimal clinically important difference is 4 to 5 points, and the estimated treatment difference between the two arms, semaglutide versus placebo, was 7.3. So this is the best data that we have on subjective quality of life and performance measures. We also know that tirzepatide, and again, in a similar population of heart failure with preserved ejection fraction, had a mean age of 65, actually had a reduction in the cumulative incidence of death over almost a 2.5 to 3 year period of time. The quality of life was actually much higher in the tirzepatide arm, so it kind of paralleled the results seen in the semaglutide studies. I'd be remiss not to talk about semaglutide and osteoarthritis. This is a recent article published within the last year. And what these authors found in individuals with osteoarthritis and obesity, that there was a significant change in body weight and the treatment difference was about 10.5%. And you can see the semaglutide arm lost about 14 plus percent of weight, which almost approximates those in the formative semaglutide trials. There was a change in WOMAC pain score that was statistically different between the placebo and the semaglutide arms. Notably, though, mean age is 56. So again, you cannot extrapolate this data to an older adult population. And importantly, close to 82% of the cohort were women. So whether or not the same results occur in men is unclear. Now, how about cardiovascular events? I showed you that some of the data, this is a retrospective analysis, but a really important one. Why do I present this? Because when you look a variety of different cardiovascular events, heart failure, atrial fibrillation, arrhythmias, peripheral vascular disease, there were statistically significant reductions in the incidence of these. Now, when you look and categorize by age group, and these are individuals 65 and up, but separated between 65 and 70, 71 and 80, and 80 plus. There's almost it's an interesting, the hazard ratio is actually higher in the older adult population of those over the age of 80. Now, keep in mind this is a retrospective study, so we want to be cautious in terms of the interpretation of the result, but it does give you pause and question as to whether or not these medications are appropriate or suitable for those old over the age of 80. How about physical function? I mentioned that one clinical trial. Um, the majority of studies have looked at both semaglutide and tirzepatide on subjective physical function using patient-reported outcome questionnaires and quality of life. Specifically, the IWQOL, which is a specific weight-related quality of life measure. What is safe to say is that physical function, subjective physical function overall was improved, as was quality of life. So what we need here is our objective measures of physical functioning, which are, again, critically lacking in our clinical trials. I promised I was going to share a little bit about gastrointestinal events, or sorry, adverse events, and particularly in older adults. There are a number of studies that have looked at this, but what I want to bring to your attention, this is a great study that looked and compared younger versus older adults, again, using the 65 cut point. And the major, the highest rates of events were all gastrointestinal related, nausea, bloating, diarrhea, and vomiting. And they're actually, the rates of these adverse events are likely dose dependent, but also higher in older adults. This is only one study, but there are a number of studies that have shown that a dose dependent effect of adverse events. So the higher the dose of your incretin mimetic, semaglutide or tirzepatide, the higher the rates of adverse events. In addition, the rates of adverse events are actually higher in older adults. So it's all weight loss the same. And I think this is really important because the majority, if not all studies thus far, are focusing on weight loss as a key primary outcome. And when we think about weight loss, we need to think about loss of fat, but also loss of fat-free mass, which includes muscle, bone, water, and viscera. And what we know, and this is a schematic, which we know that when one gains weight on the left here, one's physical function declines and one develops obesity-related complications. We know from behavioral weight loss studies that you lose 5 to 10% of your weight, you will lose fat, but you will also lose fat-free mass. However, the loss of fat likely exceeds the challenges observed with the loss of muscle, and that actually leads to improved physical performance and physical function. We also know that this would also reduce obesity-related complications. Here's the thing that we don't know. What we don't know is how much to push this weight loss. And some of the emerging anti-obesity medications that are being developed are really pushing weight loss to the extent of bariatric surgery. And will this lead to sarcopenia? It's unclear because we know that losing weight will lead to loss of fat, loss of muscle, but how is that impacting physical function? And we know from, again, from behavioral weight loss studies that you will lose lean mass, but you can, in this behavioral weight loss study, a combination of aerobic and resistant exercise actually led to improvements in physical performance and strength. So we know that you can actually improve your strength and your physical performance despite losing lean mass. However, we know that as these medications are becoming more potent, what do we have to compare it to? We have it to compare because there's a lack of data, and the data that we have is really on bariatric surgery, which has other challenges, because it changes many your microbiome, your biology, and the like. But we know from bariatric surgery, which can lead to considerable amounts of 35-40% weight loss. A majority of the weight loss that is lost is actually that of lean mass. And that's again a problem because we know that lean mass, particularly in older adults, you lose lean mass as one ages. But everybody has a threshold, which if you drop below that threshold of loss of lean mass and muscle strength, you may develop a disability and a functional impairment. What we don't know is what is that, and every person is actually different. So, what data do we have on body composition? And I think the focus when we think about incretin therapies needs to move away from just weight loss, and we need to be thinking about body composition, quality of life, and physical function. This is an older study of liraglutide. It's an earlier generation GLP-1, but you can see in a younger population, approximately 23% of the total weight loss was that of lean mass. Fast forward. Currently, there are very few studies looking at body composition in semaglutide or tirzepatide. This is one of them. The Wilding study demonstrated approximately 40% of the weight that was lost was lean body mass or fat-free mass, and this was using DEXA. That is a lot. And generally, the old adage is about a quarter of your weight is often when you lose through behavioral weight loss trials is actually fat-free mass or lean body mass. Now, I want to have you pay specific attention to this slide. And this is compliments of Dr. Locatelli and his group and their group. They demonstrated that using the SURMOUNT-1 study, this is a tirzepatide-based study, only 6% of participants were over the age of 65. But what they found, and their results said, well, the relative change, you lost weight, you actually lost your fat mass, but your percent of your lean mass actually improved after tirzepatide therapy. Well, keep in mind, fat-free mass plus fat mass have to equal 100%. So if you're reducing your fat mass percent, you're going to increase your lean mass or fat-free mass percent. I want to put it in another way on the right panel here. Individuals lost 23 kilograms of their weight. Of that, 6 kilograms was fat-free mass or lean mass, 17 kilograms was fat mass. Now, 6 kilograms of loss of fat-free mass equates to 10 years of skeletal muscle aging. That is a huge amount, particularly in older adults who have a reduced amount of skeletal muscle mass. So you're basically losing a considerable amount of skeletal muscle in those who already have a low amount to begin with. So you're asking, I worry you're asking for trouble. And again, we don't have the data to basically to support or refute whether or not that's a good or bad thing. The authors subsequently, and this is a recently published article in the last month or two, did a sub-analysis. And they said, well, the lean mass amongst different age groups was no different. Those over the age of 65 were similar to those between 50 and 65 and those under the age of 50. I do want to bring to your attention, though, that we're talking about 14 individuals on tirzepatide and 6 in the placebo. In my mind, you can't make a determination to say the statements that have been shared in this study. Another study actually looked at MRI. And I thought this was really interesting because they actually stratified by age, 60 and above versus 60 and below. And what they actually found was that um, fat infiltration actually was markedly reduced with the higher doses of tirzepatide. However, muscle volume diminished in more so in those over the age of 60. They created a Z score based on radiological data. And again, I worry that, well, it's good that you're reducing your intramuscular fat. And that's MRI is a gold standard to be able to assess that. But what's happening in our older adult population? If your total muscle volume is decreasing, I worry that could be an issue. So there are very few studies to be able to hopefully mitigate this loss of lean mass that occurs with incretin therapies. This is a study published only a few years ago, but looked at the exercise with liraglutide, again, an older generation that leads to about 5% weight loss. But what they found is that exercise actually led to, despite the loss of weight, and this group lost about 3.4 kilograms of body mass, actually led to an improvement, an increase in lean mass. So there's promise that there are modalities that can help mitigate the loss of lean mass. It's important to note, though, we talked about weight loss in muscle. We should talk about weight loss in bone. We know that even with behavioral weight loss, with caloric restriction alone, you can lose bone mineral density. And this study on the left is actually a Villarreal study, which demonstrated that a combination of diet and aerobic and resistant exercise actually didn't lead, mitigated and prevented loss of total bone mineral density at the hip. But they lost between 5 and 10% of their weight. Those in the Roux-en-Y gastric and adjustable gastric banding group is a different story. These individuals, they have, again, metabolic challenges as a result of restrictive and malabsorption procedures, but the risk of fracture actually is much higher. Where do semaglutide and tirzepatide lie in this? Well, we know liraglutide actually leads to uh, worsening of total hip and lumbar bone mineral density. Exercise blunts that. How about semaglutide? We don't have data just yet, but what we do know is that bone markers, and these are bone markers suggestive of bone turnover, are much higher in semaglutide compared to placebo. And we need to be mindful of that when we're prescribing these medications. I mentioned in an earlier slide that there's weight regain after we stop these medications. We do not have data right now on what happens to body composition after weight regain. What we do have is this study here that demonstrates after weight loss initiatives, those stopping actually gain more fat than muscle. So we need to be mindful in patients that are either intolerant, lose incretin therapy as a result of insurance procedures, that you're going to gain weight and you're likely going to gain more fat than muscle, and that could be again a big problem. So the last couple of slides, I really want to just tie all this in. I want to make sure that I convey to the audience here that medications, anti-obesity medications, are one tool in our armamentarium, but really comprehensive lifestyle interventions are the foundation of any weight loss intervention, pharmacological or not. And you really need an interprofessional team focusing on key dietary changes, and many of these are ones that I recommend to my own patients. Protein is really important. Older adults produce less protein. Bump that protein up. Really, you need a bigger bang for the buck for the protein, and try to spread the protein during the day. And there's emerging evidence that protein, leucine, as an essential amino acid, actually may be helpful in trying to mitigate weight loss induced loss of muscle mass and strength. Um, Individually tailored exercise programs, resistant exercise, by far is critically important in weight loss interventions. That's not to say that we shouldn't be encouraging our patients to think about aerobic exercise at 150 minutes per week, but resistant exercise, it's been proven time and time again, not only through lifestyle interventions, the liraglutide study, but also in interventions focusing on sarcopenia and frailty, that it is really key to engage our patients. Start low, go slow, and refer to physical therapy. So, in an ideal utopian world, I always like to say, if you're going to start individuals on incretins, think body composition, think bone density. If you can measure it, great. But chances, unfortunately, there are regulatory barriers. Try to objectively assess physical performance. The Global Leadership Initiative for Sarcopenia, referenced below, actually uses these measures to measure physical performance. Slow weight loss may be the way to go, particularly in older adults. Adjust medications and be mindful of polypharmacy as well. So I always say pause before prescribing and think about what can occur, what are the complications, where are they on the trajectory of sarcopenia, and will weight loss induce or exacerbate sarcopenia? And think about long-term consequences. These are some of the, this is my expert opinion. I usually treat individuals up to an upper age of 85, make sure that they can afford the medication, that there aren't insurance barriers, get them involved in community resources, look at their med list. Are there ones that lead to weight gain? They should critically be participating in aerobic and resistant exercise activities and comprehensive lifestyle interventions. I tend to be a bit cautious in my patients with osteopenia and really think about patient-centered strategies. And finally, and probably most importantly here, where are they on the trajectory of sarcopenia? Are they on the verge of disability? Because if you're going to lose muscle mass and strength, you're going to run into more problems. And with that, I want to thank you for your time and happy to entertain any questions that you may have.
Thank you so much, Dr. Batsis. I'm just thrilled to have you share your expertise on the topic. It's certainly one we hear a lot about. We see new research articles every day, and it's great to hear you talk about the importance of incorporating comprehensive lifestyle interventions as an additive to the use of these medications. I'm just curious a little bit about from the arthritis side, what considerations might or additional considerations you would offer when considering these medications for someone with arthritis if they are also if they do also have obesity or overweight.
Yeah, that's a great question, and been privileged to be part of the alliance that we put on some guidelines, in terms of and recommendations in terms of specific diets, for instance. So as part of the comprehensive lifestyle interventions, but specifically for medications, the study that I presented is really formative and foundational, I think, for persons with osteoarthritis. And one of the things that I hear more and more at different conferences as well is, can we use some of these medications to bridge individuals, say for a knee replacement? If they have end stage knee OA, can we get them, in a better physical performance status, better functional status, have them lose some more fat than muscle to be able to get them to a point where maybe their risk for perioperative surgery is low. So I think there's a lot of potential here. And but again, what we need to figure out is who are the right patients, and we're not quite there yet. We have a lot of work to do on that.
Yeah, it seems like a lot more research is needed on these medications in a lot of areas. If anyone does have questions for Dr. Batsis, feel free to type those into the chat. We have just a couple of minutes where we can take a question or so. Kind of related to your last comment, Dr. Batsis, what regulatory changes would you recommend or do you think are needed to ensure safe and effective treatment for arthritis with these medications?
Oh, that's a great question. And really, this is where I always say, like, what's the pie in the sky, with regard to how can we change our system? In addition to kind of, there's the Reduce and Reduce Obesity Act. There's coverage of anti-obesity medications in Medicare Part D that need, from a policy making standpoint. But importantly, in clinical practice, we need to figure out, how do we assess body composition with these medications? How do we assess physical performance in the clinic and ensure that they're done and they're reimbursed. Because unfortunately, unless anything is reimbursed, implementing something in a clinical workflow is not going to happen. And and this is a deliberate reason why I said beyond weight loss in the title of my talk, because we really need to go beyond just the number, and in kilograms, and we need to go beyond body mass index as a measure as well. We need to be looking. Obesity is a disease characterized by excess adiposity. We need to be able to measure that.
Dr. Batsis, I think I'm going to squeeze in one last question here. Have there been any studies where GLP-1s have been stacked with testosterone or growth hormones?
Yeah, not necessarily testosterone or growth hormone, but stay tuned because there are, and I didn't have time to talk about this, but there are newer agents. Some are cousins to testosterone, and that are demonstrating improvements in stair power and reductions in fat and improvements in lean and fat-free mass. Some preliminary data came out earlier this year that demonstrated, in conjunction with semaglutide, remarkable mitigation of loss of lean mass. And then, in addition, there are activin 2 receptor agonists and myostatin inhibitors that are. They're actually going to be some of this data is going to be presented this weekend at American Diabetes Association. So looking forward to hearing about those studies.
Great, thank you. I don't see any more questions, so we will wrap it up there. I'm going to quickly launch a poll. If you have time to take that before you leave, we would appreciate it. And I'll just remind you that we will be having two more presentations on the topic of weight management and arthritis later this year, one in September and one in October. So stay tuned for those details and hope you can join us for those presentations. Finally, we hope you will join us next month on July 16th at 12 p.m. Eastern Time for our presentation entitled Tech and Innovation in Osteoarthritis Care, a Biomechanical Perspective, featuring Dr. Nina Chaw from APOS Health. Dr. Batsis, thank you so much for your presentation, and thank you so much to everyone who joined us today.
Thanks, Katie, and thanks for everybody for joining today.